Alright, so let's keep talking about the hip, and in this series we're going to focus on some of the bony alignment characteristics of the hip and which implications that might have, whether it's osteoarthritis or other weaknesses and other things such as that. To start off with a little statistic, Hunter and Wilson found that more than 90% of hip OA cases were due to anatomical abnormalities. There is this quote here from the textbook: contrary to popular belief, repetitive weight-bearing exercise, specifically running, was found to have no association between osteoarthritic changes and running status among older subjects. There is this widestream belief that if we use our joints a lot more, they will degrade or degenerate or wear out quicker. And that's simply not necessarily the case in all individuals. In some individuals, that is very much the case, and if they were to run, it would cause arthritis. But across the general population, weight-bearing exercises such as running are tended to be viewed as a good thing. So with that, let's talk about some of the angulation characteristics. It really has to do with the shape of our hips. The shape of our hips determines our propensity to develop an arthritis, our propensity to produce force, to become more adept at running or other activities. And in particular, we're going to look at two types. So we're going to start talking about the angle of inclination, which is essentially this frontal plane movement. So it's how much movement in this frontal plane between the femoral head right here and the femoral neck, and how that's related to the shaft of the femur itself. After that, we'll talk about the angle of torsion, which is not pictured up here. This is going to be a transverse plane movement involving rotation, just like the angle of torsion at the shoulder with anteversion and retroversion. So let's start talking about the angle of inclination first, and here's some visuals. So I think this was on a previous slide, but it's good to know this. So there's Coxa Valga, kind of looks to me like a straight up and down L almost, or it's more just vertical in nature. And then there's Coxa Vera, which would be on the other end. And then there's your general normal angle of inclination. So the normal range for inclination in most individuals should be around 110 to 144. That's your general range. Now, in particular, if you need to know a number for that, what does the textbook list as the average or the approximate? 125 is a good number to know right there. So there you go, 125. So looking at the image, if this were, it looks pretty close to about 90 degrees. If that were 90 degrees for Coxa Vera, you're looking at that. If this line was straight vertical, wouldn't really exist quite like that, but if that were straight vertical, that'd be 180, and so then you're looking somewhere in the middle at 125 or so. Now on this next x-ray, this isn't quite vertical, but you can see it's very pronounced. It's a very significant Coxa Valga, almost like an L shape right there. So for this angle of inclination, you could see that it's significantly greater than normal. So if normal is around 125, and if a straight vertical line would be 180, this almost looks like 170 or so. I'm not sure, but it's a very pronounced Coxa Valga. So with this, it does decrease the amount of femoral articular surface in contact with the dome of the acetabulum. And if you look at this, because you have this straight vertical alignment, would you think this generally makes the hip more or less stable? Well, for the most part, because of this alignment, it's going to remove stability of the hip, so it makes it less stable. Let's look at Coxa Vera, and this is a decrease in the angle of inclination. So if 125 is normal, this is a little bit of an extreme case, this is even below 90. So if 90 were to be there, and so you can see this is below 90, I'll just say maybe that's 75 5 degrees or something like that. Certainly this could be caused by trauma, but it does create some differences here. It increases the length of the moment arm of the hip abductor muscles by increasing the distance between the femoral head and the greater trochanter. So if the femoral head would be there and the greater trochanter would be there, now you've changed that distance. You've increased that length of the moment arm. So this is also an abnormality, but does this generally make the hip more or less stable? Well, in this case, it would add a little bit of stability to the hip, so you could look at it that way as well. Another condition that may be related to this, not necessarily, but it could be related to this, is your slipped capital femoral epiphysis, and you'll see this commonly abbreviated as SCFE. It is tending to be more common in the adolescent population, and it does happen whenever the femoral head displaces posteriorly, so this would be a posterior hip dislocation. And this occurs primarily at the level of the epiphyseal plate or the growth plate. And in particular for this, it is associated with typically a coxa vara. And what else is it associated with? It's associated with a high BMI. So let me type that in there for you. Or a body mass index. Because with the increased mass running through the hip, it does also increase the shear force across the physis. This can cause a widening of the femoral head-neck junction and lead to other issues within the acetabulum. What do you think it leads to within the acetabulum? High BMI, increased mass. So this can lead to impingement of the structures, and in particular we're dealing with the hip, so we're going to refer to this as femoroacetabular impingement, or FAI. Alright, so that was the first one. Now let's talk about the angle of torsion of the femur. So this is in the transverse plane. So if you could look at this, this is that aerial view. So you're looking down the femur. Obviously the head and the neck are right there. And then what you're seeing basically the knee joint over here. So these are your femoral condyles right there. And so you're looking at your knee joint. And you're looking at this angle right there. So the amount of angulation between right there. So if you were to take the femoral condyles and you were to put them against a wall, and you'd notice that, okay, so there's a flatness to the wall, and then the neck of the femur would actually not be against the wall, and the head would not be against the wall, but there would be this angulation right there. This is considered because the head is anterior to this line right here, so this is going to be considered an anteversion. And in particular, for anteversion, we are generally looking about a 15 to 20 degree range. And if you go back and you think about the shoulders, can you name the amount of retroversion or torsional change that the glenohumeral joint typically has? So for the shoulder, yes, we know it's around 30 degrees. So with that, if the hips are around 15 degrees, there's this little saying, the hips are about half as cool as the shoulders. So 30 for the shoulders, retroversion, which is going to influence transverse plane movement, internal and external rotation, and generally about 15 to possibly 20 degrees for the hip. How did that happen? Looks like there's a little cheesy joke slide. Okay, well, it's already on here, so I don't even have to ask Alexa for this one. Okay, here we go. So how did Darth Vader know what Luke got him for Christmas? He felt his presence. Presence? Get it? Presence? Yeah, okay, so there we go. Clean this up and we'll keep going here. Okay, so here we go. So for this, here's a nice summary slide here, and in particular, pay attention to this picture down here, and it shows how the foot may be positioned differently depending on the hip angle. Because the foot is going to be the end segment, the most distal segment of this closed kinematic chain, if the hip is positioned a certain way, and so you see here in standing, so these two pictures are in standing, if the foot is positioned a certain way, such as this, such as being toed in, and sometimes we say the feet kind of make the shape like a letter A. So if you stand up and you put your toes together, you see that A type shape. Anteversion, if there's excessive anteversion, generally we associate that with being toed in. Now you could compensate, and in this case what we're having occur here is you're getting tibial external rotation to compensate for the hip internal rotation. So the femur is still medially rotated, but now the tibia is laterally rotated. And I say that because if you have a patient and their foot is straight vertical like this, each foot is at 12 o'clock, and you may think, oh, they don't have anteversion. Well, they still might have anteversion. You have to look at the tibia rotation a little bit as well. Now, what if you get them in a different position? What if you get them in a supine position? You generally may notice that this occurs. And some of you will lay supine, and then your feet will externally rotate, your legs will externally rotate a lot or internally rotate a lot. You can also look at this at prone to a certain extent as well. So just some different variations of this. But this is not going to be a really good way to determine if someone is anteverted or retroverted. There are some other better ways to measure this. Now, conversely, besides anteversion, there could be a retroversion, which would basically mean that the femoral condyles are parallel with that. So technically, this would be a 0-degree retroversion. But the way this works, at the shoulder as well, which is somewhat confusing, I think, if you have less anteversion than normal, so let's say you're at 10 degrees of anteversion, you're still technically anteverted, but we're going to say because it's below the normative value, you're actually retroverted. So you can say it, you can document it different ways, but with this is your normal up here, this is anteverted here, so it's higher, and this would be lower than 15. We're approaching 0 degrees, but it doesn't have to be a negative number below 0 degrees. And it seems to be that patient with symptomatic labral tears, which can be related to femoroacetabular impingement, have reduced anteversion. So it's important to tie the structure together with the soft tissues. Now, looking at common characteristics, you have your toe-in type pattern. This is generally associated with excessive femoral anteversion. So just think about how the feet kind of make that A type shape if you're looking at it from the perspective of the individual. It can, I don't want to say it always does, it's a common pattern to see anteversion associated with a toe in. Conversely, on the other end, if you look at the opposite here, so if you look at a femoral retroversion, this may be associated more with your toeing out, such as what you see there. So that's possible as well. So for a quick summary of all of this, this is a nice slide to know and to look at how those different positions may occur. They got the shoe and the shoelace, so you can see kind of that's definitely the foot, and this would be typically in a closed kinematic chain while standing. And then the last thing to go over for this lecture is to just quickly review some of the ligaments within the hip. There are generally 3 primary ligaments, so we'll go through these one at a time. Like anything, there is some conflicting evidence on this, but what I'm going to focus on is this consensus. That's what I want to focus on. What is the consensus of what these ligaments do? We know that they all limit at least one portion, and it does seem to be dependent. Which portion that is? It depends on the position that the hip is in. And part of the way that I think it's best to remember this, or to learn this material, is to look at these pictures right here. So look at this slide, and if you have the pubofemoral ligament, if you could just picture what that looks like. If you have the iliofemoral ligament, if you could just picture what that looks like, you won't really have to memorize what motions they restrict, because if you look at the way the fibers are going and you look at the position, so if this is the anterior view, it makes sense that these fibers right here would be lengthened if I take the hip into the posterior direction, and they're going to be shortened if I bring it into flexion. So you could tell from that basically the iliofemoral ligament doesn't restrict flexion. It would be shortened in flexion, so it wouldn't help to do that. And the ischiofemoral ligament is another one to look at here, and you see how it's kind of this wavy shape as well. So I think that's all going to be helpful. But one other key point that I just want to make with this, in terms of all the ligaments at the hip, they all tend to limit any type of hip distraction. So if we were to take the hip and we were to pull it down in this direction, if we were to pull that away from the acetabulum, all those ligaments would help to keep that in place, in position to a certain extent. So it adds to the overall stability of the hip. Okay, so let's discuss these one at a time and just quickly go over this. If you want to look at the textbook information, page 330, it summarizes these as well. So with the pubofemoral ligament, you can kind of see the way that it is going right there. And this helps on the femoral neck and connects it to the iliofemoral and ischiofemoral ligament. In particular, if the hip is extended, so the hip, imagine that femur were extended back, it would prevent motion in this direction. So it's going to prevent that swing, that external rotation position. Because you could see if I were to externally rotate or swing the femur that way, it would lengthen the pubofemoral ligament. For the iliofemoral ligament, we often call this the Y ligament of Bigelow, and this is a really strong, powerful ligament. You'll notice that there are two bands to it, so two portions, and it kind of makes that letter Y that you can see there. And in particular, this ligament is going to resist excessive external rotation as well. So we'll put this in here. The posterior ligaments, and in general, I should mention that the posterior ligaments are generally weaker as opposed to the anterior ligament. But for the posterior ligament, in particular the ischiofemoral ligament, you'll notice that this one has three bands, so three smaller bands with that, and this is going to be the primary restraint to internal rotation or medial rotation. If the hip were to go medially, you can see that that would lengthen these structures. The other thing that's unique about this, and this is the part that I would say varies between sources, is that if the hip were to extend back further, so this is a posterior view, and if you can imagine the hip extending back further, it would sort of wind up this ligament. So some sources would say this would actually limit hyperextension, which is counterintuitive because you think of posterior structures generally limiting flexion, but in this case, because of the twisting of these fibers, hyperextension might be limited, but there would have to be a lot of hyperextension. So if the Y ligament of Bigelow were torn, or some of the anterior ligaments were torn, then this ischiofemoral ligament might kick in. So it's not going to be the main one to limit that. If you think of ischiofemoral, you should think of that as limiting internal rotation. That would be the thing to think about. Okay, so let's go to the last slide for this, capsuloligamentous tension. This ties into the closed pack position, so you're going to have the hip extension, you have hip internal rotation and then a slight abduction. I sort of think almost like the position you're about to wind up to kick a ball or something. You're going into that hip extension, internal rotation, slight abduction position. So let's say you had a car accident and your knee, so you hit a car in front of you and your knee were to hit the dashboard. So the femur is coming in from the dashboard, so that's why this arrow's looking in this direction, and it's forcing the femur into the posterior part of the capsule. This may result in a posterior hip dislocation. So that's the last thing for this slide. I will also show a video of Craig's test, which is a way of measuring anteversion in the angle with that. So you can look at that in this next video. Thank you.
Perform the test. Place the patient in prone and flex the knee. Rotate the femur until the greater trochanter reaches its most prominent point laterally. Now measure the angle of the tibia off the vertical axis. A normal angle is between 8 to 15 degrees. An angle greater than 15 degrees indicates increased femoral anteversion.